Hello, my name is Carrie Ann Larson, and for this presentation, I'll be discussing post-traumatic stress disorder, or PTSD, in the pediatric population. PTSD is a set of symptoms that develop after an actual or threatened exposure to a stressor or trauma. The exact etiology of PTSD has been found to be dependent on the individual's ability to be resilient and adapt positively to adversity. The immediate physiologic response to trauma can lead to alterations in both the structure and function of the brain. These include lower levels of cortisol, elevated levels of the corticotropin-releasing factor, a smaller hippocampus, an overly reactive amygdala, and a medial prefrontal cortex that is smaller and less responsive. Those who are a younger age are more at risk for developing PTSD. This is related to the decreased emotional and intellectual resources that are needed to cope to adverse events. Furthermore, out of the 15 to 43% of children who suffer from a traumatic event, 3 to 15% of girls will develop PTSD when compared to 1 to 6% of boys. Second, an individual is at risk if they find themselves more likely to witness or be involved in any traumatic or serious events, sudden death of a loved one, history of mental health disorder, and/or history of drug and alcohol misuse. The signs and symptoms of PTSD can be categorized into various groups. First is intrusion, where they relive the traumatic event. Second is avoidance, where they avoid situations that remind them of that event. Third is detachment, where they have feelings of disinterest from others or their normal activities. Fourth is negative mood or beliefs about oneself and the world. Fifth is negative cognition, where they might have amnesia to part of the traumatic event. And lastly is arousal and reactivity, where they experience problems with sleep, reckless behavior, hypervigilance, and an exaggerated startle response. For this case study, we'll look at a 6-year-old with a past medical history of ADHD and cranial stenosis syndrome that required frontal-orbital advancement surgery at the age of 2. This patient was referred to psychiatric emergency care. Patient's parents reported that he had been experiencing worsening aggression and outbursts, sleep problems, increased arousal, exaggerated startle, hypervigilance, and behavioral reenactment for the past 3 years. Patient's mother added that this behavior was worse when he was brought to the hospital for the management of his cranial stenosis syndrome. This patient had experienced a post-surgical complication of septicemia that required a prolonged hospital stay. The patient's behavioral symptoms that previously led to the diagnosis of ADHD, and he had been started on Adderall and Clonidine 1 year prior without significant improvement. The patient's history and symptoms were then reviewed under the DSM-5 criteria for both ADHD and PTSD. It was found that the child was not fulfilling the entire criteria for ADHD, but he had fulfilled the criteria for a diagnosis of PTSD. There are no specific laboratory or imaging studies that can confirm the diagnosis of PTSD. Therefore, the screening and assessment requires careful and direct clinical interviews with the patient and their caregivers. The provider can utilize one or more of the psychological instruments that are listed on this table for assessing traumatic stress in young children that can be completed by the patient and/or caregiver during these interviews. The ultimate goals of the assessment are to ascertain that a trauma has occurred, identify the nature of the trauma, and recognize the consequent symptom pattern. The DSM-5 reports that a diagnosis of PTSD requires that the child demonstrate specific behaviors following trauma. First, the patient must repeatedly re-experience a set of symptoms from each of the 3 following categories: intrusive memories of the trauma, nightmares, and distress caused by cues that resemble the trauma. Next, they must demonstrate 3 of the following symptoms that reflects avoidance of stimuli associated with traumatic events. Lastly, they must have 2 persistent symptoms of increased arousal that must be new, present for at least 1 month, and cause clinically important distress or negatively affect their functioning. The most common differential diagnosis for PTSD is anxiety disorders. However, they're not precipitated by a traumatic event. Next, we have acute stress disorder, which is a reaction that occurs after a traumatic event, yet symptoms usually resolve within a 4-week period of time. The third differential is OCD, due to the recurrent intrusive thoughts, and the last differential diagnosis is psychosis, due to their flashbacks, intrusive images, and cognitive disorganization. However, both OCD and psychosis are unrelated to an experienced trauma. Children who receive a diagnosis of PTSD should receive referral to a pediatric behavioral health specialist, as well as a report to social service agencies if they're younger than 18. If the patient is unable to get into a specialist right away, many child abuse intervention centers are prepared to accept referrals and direct patient management. Psychotherapy is the core of PTSD treatment, with trauma-focused CBT showing the most promise. EMDR therapy is not as well studied, but also shows promise as an effective therapy strategy. Lastly, pharmacotherapy is not well supported in children. However, research has found that beta blockers may decrease somatic symptoms, while SSRIs can help with the symptoms of anxiety and depression. The average duration of symptoms if treated is 36 months, and if untreated is 64 months. While almost 50% of patients will experience significant reduction in symptoms, more than 1/3 will never fully remit. Thus, these patients will require long-term monitoring, educational support, and social skills training to help gain back skills that might not have been developed during periods of withdrawal. Providers should also consider administering an assessment tool on a monthly basis to monitor symptom change over time. Thank you for taking the time to watch this video, and if you have any questions, you can shoot me an email.